Dear friends and colleagues from all over the world, my name is Vincent C. I'm a urologist from Sydney, Australia, and I'm co-chairing this session, which is the Pan-Pacific Continence Society session with Professor Hidehiro Kakizaki from Asahikawa in Hokkaido, Japan. And the Asia-Pacific region constitutes approximately 30% of total ICS membership. And as you all know from attending the ICS meetings over the years, that much high quality work and research comes out of this part of the world. And we indeed, the local organizing committee indeed is very grateful for the ICS Board of Trustees for allowing and supporting us to have this PPCS session at this year's Melbourne online meeting. And this is indeed the first time that the Pan-Pacific Continence Society have a activity at an ICS annual meeting. I'd like to let Professor Kakizaki say a few words and introduce all of you to the PPCS. Thank you, Professor Kakizaki.
Hello, everyone. My name is Hidehiro Kakizaki. I'm this year's president of PPCS. I welcome all of you for participating in this PPCS session. I'd like to briefly introduce the history of PPCS. The PPCS was originally developed by the friendship and collaboration between the Korean Continence Society, Taiwanese Continence Society, and Japanese Continence Society. The first PPCS meeting was held in 2006 in Tokyo. Then meeting press was rotated every year among Japan, Korea, and Taiwan. Then China, Australia, New Zealand, and Indonesia joined the PPCS. The PPCS is a platform to exchange scientific knowledge and clinical experience to promote evaluation and management of lower urinary tract dysfunction. Today, I'm very glad to moderate this PPCS session together with Vincent. Now, Vincent, back to you.
Thank you, Professor Kakizaki. I would like all of you to make comments on in the functionality on the platform, and please introduce your country as well. And also, please join us in the live lounge to meet us and network with us at the end of this session. I would now like to introduce the first of our 7 speakers coming from 7 different member countries of PPCS. And Professor Harina Erlianti from University of Indonesia, Jakarta, will present her work, which was recently published in the Journal of Urology, which is a meta-analysis of pelvic floor muscle training before and after radical prostatectomy. Please, Harina.
Thank you, Professor Vincent C. for the introduction. And thank you for the committee for the opportunity to present this topic, which titled The Pelvic Floor Muscle Training Before and After Radical Prostatectomy, What are the Evidence? This is my disclosure, and I have nothing to disclose. So prostate cancer is a common cancer in men, and prostatectomy is the most common treatment. However, up to 60% of men may experience post-prostatectomy incontinence, and up to 30% will experience it 1 year after treatment. So continence depends on smooth muscle of the urethra and the contraction of the striated urethral sphincter, or the SUS, the puborectal or pubovisceral and bulbocavernosus muscle. The radical prostatectomy removes the prostatic segment of the urethra, the internal sphincter, and may remove or damage the SUS muscle or its innervation, causing the post-prostatectomy incontinence. The pelvic floor muscle training would help to increase the muscle tone through 2 regimens. The conventional one, which is the repeated maximal contraction of the muscle around the anus, And the urethral training, which is an individualized pelvic floor muscle training program focused on the SUS, the puborectal and the pubogovernosus muscle. So we're going to take a look at the sum of the evidence. So this first is the systematic review, which compared the pelvic floor muscle training alone or in combination with no treatment, placebo, or sham. So PFMT or combination were more effective than no treatment for PPI in terms of number of incontinent men immediately following intervention and also number of continent men at follow-up. However, no significant difference in urinary weight on pad per 1 hour, both following intervention and at follow-up. This is another meta-analysis showing that better outcomes for pelvic floor muscle training than control groups when the study included the pre-operative training compared to just post-operative training. This is from the same study compared with the pelvic floor muscle training focused on the anal region only. The instruction involving the urethral and anal region showing that it would increase the efficacy of pelvic floor muscle training. Another result was there was a better outcomes for pelvic floor muscle training than control if the pelvic floor muscle training was combined with biofeedback compared to PFMT only. This is another study comparing pre-op and post-op PFMT. And there was a significantly better outcomes for pelvic floor muscle training than control groups if it was done pre-operatively. The pad weight was significantly lower and dry percentage were significantly higher in patients who underwent PFMT before radical prostatectomy. And the IPSS and incontinence score was significantly better in patients who underwent PFMT before radical prostatectomy. So this is a recent paper from our center. This is a meta-analysis from the effect of pelvic floor muscle training on incontinence problems after radical prostatectomy. We reviewed articles and then we included 12 eligible studies in this review, 11 of which we included in the meta-analysis. And the result was that the pelvic floor muscle training initiated pre-operatively significantly reduced the incidence of persistent urinary incontinence at 1, 3, and 6 months post-op. And there was no difference in an improvement in patients' incontinence at 12 months post-op. So in conclusion, the pelvic floor muscle treatment may decrease urinary incontinence in men after radical prostatectomy, but several factors would increase the effect of pelvic floor muscle training, including pre-op treatment, instruction involving urethral region of pelvic muscle, or the use of biofeedback. So thank you for your attention.
Thank you very much, Professor Rahaujo. So I'm just scrolling through now. There hasn't been any questions yet. So can I ask you one question? Did you say that the conclusion in the meta-analysis is after 12 months, there is no difference? So are you saying they should be stopping doing pelvic floor muscle exercises?
Yes, the reason behind that was that there were only 3 studies that monitored the success of the PFMT until 12 months. Comparing to 1, 3, and 6, we can see from the 11 studies that were monitoring after 6 months, but there were only scars or only 3 studies monitoring beyond 6 months and reaching the 12 months. So maybe that's why that the 12 months it was not significant.
Okay.
So yeah.
So it's just that it hasn't been studied beyond 12 months because it just makes so much sense that I think every man should continue their pelvic floor muscle training. Probably forever. And we'll probably hear maybe from Professor Su in the last talk, because when they age, to their 70s and 80s, it'll be interesting to see what their continence rates are if they've had a radical prostatectomy years before. Yeah. So thank you very much for your presentation. I just double check here. Yeah, so we'll go to the next presenter, and I'll let Professor Kakizaki to introduce.
Okay, next speaker is Dr. Justin Lin from Taiwan, and he's talking about the role of urodynamics before anti-incontinence surgery. Dr. Lin, could you please start your talk? Dr. Lin? Okay, yeah.
Can you hear me?
Yes.
Yeah. Sorry. Hello, everyone. Today, I really have the honor to present the topic, why should we do urodynamics before offering anti-incontinence surgery? I have nothing to disclose. If we want to answer this question, we need to check the AUA SUFU guideline for incontinence after prostate treatment. We focus on here. This is the evaluation algorithm. We focus here. When will we go to the cystoscopy and or urodynamics? Only other pathology suspected. But I think maybe we need to have a look at the EAU guideline. Does urodynamic influence the outcome of treatment for prostatectomy urinary incontinence in men? We know that urodynamic will help to distinguish the causes of incontinence, but there is no randomized control trials, and this is uncertain to predict the outcome of surgery for incontinence for this man. So I think we need to have an idea is that before the anti-incontinence surgery, we need to answer this. What's the pathophysiology of the incontinence? Is it a result of ISD, detrusor overactivity, or diminished compliance of bladder outlet obstruction with overflow? Or is there any adequate bladder contractility? Or is there any high pressure storage due to impaired bladder compliance? Is there DO? Is there BOO? Is there bladder neck or urethral mobility? So if we want to answer this question, we need to perform the urodynamics. So if these patients with PPI receiving urodynamics, what's the possible finding? The most percentage, 90% is ISD, intrinsic sphincter deficiency. And 30 to 40% is DO and decreased contractility. So we need to find out, is there any DO, is there any DU, or any BOO? And what's the cause of the bladder dysfunction? We need to know the pre-existing problem before prostatectomy. If this is pre-existing, like bladder outlet obstruction, age-related DO, maybe you will another cause for the after operation. Or is there any de novo situation like bladder denervation, obstruction due to anastomotic stricture, impaired detrusor contractility, or poor compliance? So different etiology make the treatment option different. So if you have the situation, the diagnosis is post-prostatectomy, SUI, maybe we will arrange the surgical management, injection, the peri-urethral bulking agent, Melslin AUAs, or like DO, we will give the anti-muscarinic beta-3 agonist. Or for the refractory DO problem, we need to have the Botox A injection or neuromodulation. If the patient have the DU or BOO, to make the overflow incontinence, we need to have the intermittent self-catheterization. So different options, different etiology make the treatment option different. So we still need to know that etiology. So we need to perform the urodynamics. Then we will move forward to the different situation, such as the DU. DU, we also know that is with distressor contractility, but this condition will make the situation relative contraindication to male sling surgery. We know that it's higher risk for retention after sling surgery. But the diagnosis of DU, we need to know that vascular voiding and the low P to trusor pressure. And so maybe BCI is not be adequate, accurate for the measurement for strength. So we need to know we can have the measurement like P-ISO. It's to make the patient to have the stop during the contraction. Another situation is detrusor overactivity. I think it's supraphysiologic infusion to the bladders because of continual urine leakage. So if patient have the DO with ISD, not an absolute contraindication to AUS and slim plasmid. Here is the impaired compliance. We need to know that it's contraindication to male sling, but in some patients, it can have a high success in AUS. And I think that ALPP the value is debatable. We can see here no correlation between the ALPP and the pad weight. Finally, the VUDS, the meaning for the check the VUDS is we can understand the useful for determining the degree of proximal urethra and bladder neck mobility. So we can do some tests to know the situation of the urethra mobility. If its mobility is high, maybe we can consider retroluminal transobturator sling. If the situation is restricted mobility, maybe we can consider compressive sling and artificial sphincter. So here are the take-home message. It is important that urodynamics are only performed when there is a question that can be answered, and that answer would affect the treatment choice of our outcome. So if you want to ask me, maybe we can just have a look at the algorithm from AUA, SUFU, and EU guideline. Maybe we still need to know something if we want to treat the patient appropriately. Thank you for your attention.
Thank you, Dr. Lin. Very nice presentation. And so far, there is no question from the audience. So I'm going to ask you a few questions. So you said that 90% of patients with post-prostatectomy incontinence, about 90% have an intrinsic sphincter deficiency. They also 30 to 40% have detrusor overactivities, and I quite agree with the result and your opinion. So what is the best appropriate timing of urodynamic study for patients with post-prostatectomy incontinence?
I think maybe the good timing is 6 months later. Maybe the situation is more stabilized. Yes, and I think in the timing between postoperative 1 month to 3 months, maybe the situation not so stabilized. Yeah.
So you said that we have to wait at least 6 months.
Yeah, maybe we can do it early in post-operative 3 months. But I think maybe we can just can give you some medication such as duloxetine, yes, SSRI.
But in my clinical practice, I usually wait until 1 year because when the post-processing content gradually improve in 6 months, 3 months, 6 months, and 9 months, and then 1 year. So probably in many urologists in Japan are waiting for 1 year to know some spontaneous recovery. And
you should
Vincent,
know
do you
that.
have any? Vincent, do you have any question?
I haven't seen any here, but I will also ask Dr. Lin. So in a patient who you discovered reduced bladder compliance, for example, you are planning to do an operation on this person's incontinence and there is reduced compliance, how do you know it is a neuro-mediated poor compliance or whether it is fibrosis from the bladder wall, perhaps from BPE, from enlarged prostate and obstruction? How would you deal with this poor compliance patient?
In this kind of patients, I think it's hard to differentiate. It's pre-existing or de novo. You mean because they have before operation you have BOO, so make the bladder fibrosis. Yes. If you do before operation, maybe we can know that. But most urologists in their daily practice, I don't think they will do the urodynamic study before the prostate surgery. So, but I mean, oncological, urological oncologists. Sometimes they didn't do that often in Taiwan. For my country, it's this situation. So,
Thank you very much.
But so we just have a look at the postoperative situation. I think it's maybe we can do the video urodynamic to see the contraction during the fluoro, under the fluoroscopy. Maybe we can find out something.
Yes, thank you very much. We still got a couple of minutes. I think Professor Kim wants to ask a question. Yes. Where's Professor Kim?
I have a question. Continuing with the compliance issue, what do you think about the possibility of low compliance because of disuse? So the patient is leaking, the bladder is not filling, so the compliance is there because of the radical prostatectomy?
Yeah, probably. Maybe the sensation is decreasing. You mean that?
No, I mean, when you do a urodynamic, you see a low compliance, but maybe that's like a pseudo because it occurs, the patient didn't have that low compliance before, but it developed after a radical prostatectomy because the bladder is not filling up. So if you do an AUS or a sling and then the bladder starts to fill up, the compliance improves. So it's like a patient who goes under hemodialysis. The bladder shrinks, he's not voiding the shrinks, and there's a low compliance. And after a kidney transplant, the urine fills up and the bladder expands and the compliance improves. What do you think? Is that a possibility?
Yeah, probably. Yeah. But I did some research on the patient after operation, and I find out that most of them, the contractility decreased. Yeah, and the percentage of detrusor overactivity is not so high as I presented in my slide. Yeah.
All right. Thank you very much for the discussion. So we have Professor Helen O'Connell making a comment that many have stress urinary incontinence plus another diagnosis. So a lot of these men have mixed SUI and another diagnosis, and there is a tendency to make decisions based on just pad weight, and then they will go ahead with a anti-incontinence procedure,
Yes.
as if it is exertion related. And I think in many men, do you think that approach is harmful? Because if you don't do urodynamics, you assume every person just have ISD, and then you put a sling in or an AUS. Do you think that is harmful?
Yeah, I think probably harmful. For some patient with diffuser underactivity, if they do a slim surgery, maybe it's harmful.
Yes.
Yes.
And there are also some studies out there showing that if there's poor compliance or diffuser overactivity, if they have a sling put in, their intermediate and long-term outcome is also not so good.
Yes.
Thank you very much, Dr. Lin. We will move on to the next paper now. So I'd like to introduce Professor Masuda. Professor Masuda is from Chiba, Japan, and he is going to talk to us about a situation which we commonly encounter, which is bothersome stress incontinence in the face of a rising PSA in a patient who has positive surgical margins. And if you plan anti-incontinence surgery, should you do this before or after the radiation? Because this patient is going to need radiation. So hopefully he'll tell us the answer.
Thank you.
Thank you.
Thank you for chairperson. I am honored to be here for this presentation. And in Japan, AUS implantation has been gold standard as a surgical option for post-prostatectomy incontinence. In contrast to other countries, while male wrestler sling is not available, partially because of no support by medical insurance. We have experienced 150 cases of AUS. In our data, after operation, dramatic recovery within 6 months, followed by gradual recovery in our case. In most cases, continence status becomes stable after 12 months. But in very severe or near total incontinence cases at 6 or 12 months, incontinence will persist forever. This interesting paper indicated that adjuvant radiotherapy or radiation within 12 months after operation, that is early onset radiation, has negative impact of urinary continence recovery. Very good paper. The other also interesting paper also reported that late phase after salvage radiotherapy, progression of incontinence was found, especially in high-grade incontinence group, grade 2 or grade 3, due to the damage of microvessels with chronic hyperfusion, leading to fibrosis and atrophy of the tissues. Big dilemma. Based on above data, when we should perform SRT, considering continence status, it depends on time after RP. Within 1 year, early phase, urologist wants to delay SRT until continence recovery in patient with recovery potential. On the other hand, severe or total incontinence patient, maybe SRT may be okay within 1 year. But after 1 year, late phase, if continence status becomes stable, SRT should be performed according to oncological status. But maybe, in my opinion, recent data, upfront hormonal therapy has positive impact on effect of SRT on biochemical recurrence after operation. Thus, upfront hormonal therapy during continence recovery time, maybe 6 or within 1 year, should be considered as an additional treatment option. In contrast, In patients with severe or near total incontinence patients, recovery potential seems to be very low. When to start SRT with or without hormonal therapy depends on the oncological status. After that, AUS should be considered. This is in our series, in most cases, SRT followed by AUS. All SRT was performed after longer than 1 year after radical prostatectomy. In our data, percent device survival in our case, radiation failed to affect the device survival within 3 years. In both groups, about 90% patients can use initial implanted AUS device. Sorry.
本日22時30分から未明3時まで本館と
Sorry.
医局等にて停電作業を行います。
Also, radiation failed to increase the incidence of infection or erosion.
電気がご使用になれませんので、あらかじめご了承ください。なお、ご不明な点がございましたら、防災センター内線2197までご連絡ください。
Sorry, big accident. Only 2 cases AUS followed by SRT. But there is no case series in this situation checked by website. In both only 2 cases, ICSF total score worsened after SRT. We have few clinical data in this situation. SRT after AUS may have negative impact on the continence status due to vessel atrophy, possibly due to chronic ischemia. In Japanese preoperative AUS study, including me, ICSF score have been reported to worsen a little with time in even patients without SRT after AUS. SRT may have more negative impact of ICSF score, but I have no data. Take-home message. Radiation therapy have negative impact on continence recovery after RP within early phase within 12 months and worse incontinence severity. If possible, SRT should be delayed until continence status becomes stable. Upfront hormonal therapy during recovery status should be considered. Pre-SRT failed to affect the survival of AUS in our series. There is little information about the impact of SRT after AUS on continence outcomes. If possible, multi-center study should be needed. Thank you for your attention. Sorry.
Thank you very much, Dr. Masuda, for this presentation. The reason why myself and Professor Kakizaki put up this topic is because it is a topic that's not much in the literature, and it's more for a bit of discussion about what various people, various practitioners, or maybe in different countries, what you actually do in this situation when a patient has a rising PSA and they are quite wet and you know they're going to need salvage radiation. So should you put the patient out of their misery and put do an anti-incontinence procedure or not? And if you're going to do one, would you do a sling or would you do an artificial urinary sphincter? So I'll tell you my humble experience is I would prefer not to operate in somebody who has had radiotherapy. So if they are still very wet after about 6 months, stretch it up to a year, then I would prefer to treat that patient first before they have radiotherapy. Anyone would like to comment? Anyone in the panel would like to comment?
Yeah, I just have a question for Dr. Masuda.
Yeah.
So let's say the patient is out 2 or 3 years and he's starting to have radiation therapy. It stretches out for a period duration, and he wants AUS. Can you do it in between the radiotherapy sessions, or should you wait? And if so, how long should you wait after the radiotherapy is completed?
But a patient wants to perform AUS, but only in severe, very severe patients is maybe have low possibility recover. In patients is perform AUS is okay before SRT.
Now, how about during SRT?
During SRT. During SRT.
That is a bit of a tough situation. Usually the SRT doesn't really last that long. Why would you like to do it during the SRT? Most of us maybe.
Maybe if the patient wants it, sometimes it's longer than expected, and if, like I said, if you want to wait, how long do you have to wait after it's over, radiation? Can you do it immediately after it's over, or do you have to wait 3-6 months?
That is, yeah. I mean, I like to see what the other people think, but what the other panelists here think. But that's why in my practice I prefer for the patient not to suffer because they've already been wet for so long. How do you know when they're actually going to need the radiation? Because sometimes their PSA may rise very slowly. I mean, it may only double every 6 to 9 months. So does that mean you have to wait? Wait for the patient to wait so long? So that's why my practice is I tend to do the surgery to get them drier, and then just see what happens with their PSAs. So at least they have some better quality of life for a while. And there are also a number of papers. There are many papers out in the literature, some of them done already 10, 15 years ago, showing good quality of life, and they will recommend it to a friend, even after they've had complications like erosions in this radiotherapy cohort. So at the end of the day, these patients still fare well, and they still love their AUS, despite of the fact they have had complications and have to have revision surgery. So that's why it is probably all right to treat these men, and then even if they have radiation after this, even if you have to do a revision after it, they still do well in the long run. So any other comments? If there are no other thank you very much, Dr. Masuda, for that informative talk. So I'll have Professor Kakizaki.
Okay. Okay. Now we are moving on to treatment of post-prostatectomy incontinence. The next speaker is Dr. Jong Won Kim from Korea. He's talking about male string, which one to use. And, Dr. Kim, please start your lecture.
Thank you, Dr. Kakizaki. So, as you all know, there are numerous types of male slings available on the market today. However, there's no guideline as to how to choose a device on certain patients. This is probably due to a lack of evidence comparing the devices. But what I'm going to try to do today is give you a general approach in choosing a sling device, albeit most of it is based on just expert opinions. So this is my disclosure. And this slide shows the various options for surgery after an incontinence after radical prostatectomy. Of course, the AUS is the gold standard. But as you can see here, many types of slings are available, and they do provide some good results. The slings can be divided into a readjustable or a fixed non-adjustable type. And as you can see, the results are comparable between these two types. And because of the lack of evidence, it's very difficult to say which type of sling is better than the other. So we can, for the indication of sling, we have to consider the severity of incontinence. And basically the best patients are those with a mild degree of incontinence for slings, but this can be stretched to those patients with a moderate degree as well. So how do we determine the degree or the severity of incontinence? One of the standard method is using a pad test, and in the male, the 24-hour pad test is preferred. This can be categorized into three types: the mild, moderate, and severe, where the patient, if the leakage is less than 100 grams for 24 hours, it's considered to be mild. And those with over 400 grams is considered to have a severe type of incontinence. And those between those figures is considered to have a moderate degree. However, some people would use a 200 gram as a cutoff for a moderate degree of incontinence. So this is a slide showing some results where those leaking more than 200 grams per day showed a lower success rate with the transobturator retroluminal sling, which is a fixed sling. And those with more than 450 grams should be, the AUS should be recommended in these types of patients. As a general indication for slings, patients with a history of radiation or an AUS implantation history should not be recommended for a sling. So this slide shows a very simple test that determines the severe incontinence. This is the standing cough test that was developed by Dr. Alan Mori. And basically it divides the patients into two groups, and those that develop a stream with a cough test and those that do not. As you can see, the grade is from 0 to 4. And those that develop a stream, the AUS is recommended. And those that do not, the sling is recommended here. So if you look at the grades for the sling, the patient, I see these patients often, is that the patient complains of the leakage, but in the cough test is negative. Some would develop drops only, and some would develop early drops. So this is slide shows some of the types of the adjustable slings, including the Remix, the Atom, and the Argus system. So the Remix, the mesh is placed under the urethra and the bulbous urethra, and it's connected to a tensioning device, which can be adjusted far later after the operation. In the Adams device, a balloon attached to a mesh is placed under the urethra here, and fluid is injected to expand the balloon and adjust the expansion to adjust the compression of the urethra. For the Argus system, a silicone-based sponge is placed again under the urethra and tension adjust by pulling. And this adjustment can be performed again far later after the operation in increments. So this video shows the a knob connected to the tensioning device after a Remix operation, and the tension can be adjusted post-op. So the patient is performing a Valsalva maneuver, and the knob is turned clockwise to really pull the mesh and tighten the tension. Okay. So this slide shows the types of non-adjustable fixed slings that include the advanced, I-stop Toms, and the Virtue system, where the advanced is the most widely used. In this system, after placing the mesh at the urethra, bulbous urethra, when you pull the arms, it repositions the urethra, and this is a mechanism for continence with this device. And we can perform a repositioning test to check whether this would be successful. And what you do here is you put a cystoscope and you push the perineum gently below the bulbar urethra, which I've marked here, parallel to the anal canal. And what would happen is the area of the bladder neck here below the distal to the bladder neck would coap with the push, as seen here. And then you would ask the patient to actively contract the sphincter. And as you see on the right here, this area would coap further. So this area of coaptation is called the coap zone. And this is more than 1 centimeter in length, is considered to be positive. So this picture in the bottom shows a urethra that was irradiated. And as you can see here, the coaptation really does not really change after the patient has an active sphincter contraction. So this would not be an indication for one of those retroluminal slings. So which procedure should be performed for which patient? There's not a lot of data out there, and even the guidelines do not provide this. They just say even for the fixed or the adjustable slings, they just state that basically for the fixed sling, as some of you mentioned before, severe incontinence, history of radiation with the stricture has poor results. For the adjustable slings, the explantation rate is high. That's probably it. That's about it. So they don't recommend which procedure is better for some type of patients. However, this is an algorithm, basically is a template. I think people can use to adjust, fine tune their indication. This is a algorithm from a paper a few years back. And if a patient has a mild to moderate incontinence, he can be considered to have a sling. And if the coap zone is greater than 1 centimeter during the repositioning test, and the patient does not have a history of radiotherapy, the patient can be considered for the retrourethral transurethral male sling. However, if the patient has a history of radiation, or if the coaptive zone is less than 1 centimeter, or if the patient, despite having more than moderate degree of incontinence, has a cognitive or manual impairment, these patients can be considered for an adjustable sling. As a further option, this is just an optional indication. If the patient has, despite having a history of radiotherapy, if the repositioning test shows a coaptive zone greater than 1 centimeter, again here, the retrourethral transurethral male sling can be considered, although it is not strongly recommended. Those patients with a orthotopic neobladder or anything, fibrosis of the retropubic space, should not be recommended for those slings that uses the retropubic space, such as the Virtue system or the Remix. Okay, that's it. Thank you.
Well, Dr. Kim, thank you very much for a nice presentation. And you talk about adjustable and non-adjustable male string. And in the last part of your presentation, you show us some kind of patient selection, or which type of male string to be used for each patient. And frankly speaking, as Dr. Masuda said, that in Japan, we do not have a artificial material made sling procedure. So this type of surgery is not available in Japan. So I have never experienced about sling procedure for male patient. Although I have a few experience about autologous male sling using autologous fascia, such as a fascia ladder over this fascia. So I'd like to ask some question, comment from the panels. Is there any question or comment from the panel?
Just scrolling through the questions now. I don't think there's any. Actually, Doctor, there are a couple of questions there. So, Dr. Johan Ghani, he is from Melbourne, Australia. He wants to know from you, the adjustable transobturator sling trocar has to rotate more vertically during the insertion, and I am worried about injuring the rectum when it rotates outwards. As the trocar only comes in one size, have you had this concern, especially in the smaller male Asian pelvis?
Yes, I understand what he's trying to say. Yeah, so you really have to be, I think, diligent in the process, because there's not a large amount of space there, and you really have to use your tactile senses, and before I guess your 3D in your brain to try to imagine the course of the needle. Yeah, I understand what he's saying, but yeah, but I haven't had any issues with that. No.
Right. So just one last question, quick question. Professor Hikaru Tomoi from Japan asked you, is it possible to cause necrosis of the urethra? I suppose what she means is severe ischemia to the urethra if the remix is controlled where coughing stops urine leakage.
Yes, I've done quite a few cases of remix and actually gone back and looked at the urethra in a few of the cases. And no, it's compressed. There's fibrosis there, but I haven't really had erosion issues.
Right. And then our Secretary General, David Castro Diaz, in the experience of Dr. Kim, what is the long-term outcome of male remix? Can you give a quick summary?
Yeah, that's a great question. I think it really depends on patient selection. Long time, I started, I think, more than 10 years ago with the remix system. And when I started out, the indication was very wide. So it included more of the moderate to severe types of patients. And those patients, I think, had poor results. Since then, I've been fine-tuning toward more of the mild patients. And in the mild patients, I would say, in terms of the cough test, I've shown you before, they would be either a grade 0 or grade 1. So it just drops with the cough test if it's a very mild patient. So that's even in the long term of 4, 5, 6 years. I've had patients, I think, greater than more than 10 years out. So I think patient selection, if you select the patient right, especially with the mild patients, you would have good results. Although you would have to warn the patients of the need for adjustability in the future.
Thank you very much, Dr. Kim. So we move on to the next speaker. So we have Dr. Audrey Wang from Sydney, Australia. She is a functional and reconstructive urologist, and she'll tell us something about pearls in the surgical technique for AUS implantation after radiotherapy. Thank you, Audrey.
Thank you very much. I'll try to share my screen. Sorry, 1 second. Thank you very much for the opportunity to speak on pearls in surgical technique for implantation of artificial urinary sphincter. I have no disclosure. I would like to start with radiation effect on the lower urinary tract. Ionizing radiation creates reactive oxygen and nitrogen species, which lead to cellular damage. In cancer cells, it leads to cell death with breakage of double-stranded DNA. In normal tissue, it's hoped that it will repair itself, but it's not always the case. Cytokine release and activation of inflammatory pathway ensue, and sometimes it may lead to radiation-induced fibrosis. For the bladder, patients may present with radiation-induced hemorrhagic cystitis and overactive bladder symptoms. On urodynamic testing, the TRUSA overactivity Reduced volume at first sensation and desire to void, as well as decreased compliance may result. Also, do not forget the secondary malignancies, which occur with a prevalence of 4.5% at 5 years. For the urethra, strictures may form, which has the highest prevalence in patients treated with brachytherapy combined with external beam radiation. We know that the success rate after urethroplasty is lower in the irradiated population, and also they have a much higher incontinence rate even after successful repair. Radiation damages rhabdoid sphincter, leading to stress urinary incontinence, and also causes weakness in the pelvic floor muscle, both in terms of fibrosis structurally and weakness in contraction on EMG. Artificial urinary sphincter is the gold standard for treating SUI in the irradiated population. There is conflicting outcome data in the literature. Most contemporary series report no difference in outcome. This is very encouraging for us in knowing that AUS can be implanted safely and with good efficacy in this difficult patient population. However, others show higher complication rates. Kaufman et al. Reported radiation significantly accelerate time to erosion by 2 years. And the meta-analysis in 2015 showed higher AUS revision rates and greater persistence of urinary incontinence. So how can we optimize outcome for these patients? I would like to consider a few factors preoperatively, intra-op, and post-op. I hope Dr. Ling has convinced you to perform a urodynamic study pre-op. I cannot emphasize enough the need to exclude a urethral stricture and to assess bladder dysfunction in these patients. Particularly in terms of decreased compliance, it's akin to a high-pressure neurogenic bladder with upper tract implications. For those with radiation-induced hemorrhagic cystitis, hyperbaric oxygen therapy has shown to be effective in achieving partial or complete response. In one paper, they also report a decrease in bothersome LUTs. It raises the possibility of using hyperbaric oxygen as a primary or adjunctive treatment for radiation-induced LUTs. Anecdotally, specialists in hyperbaric medicine in my area would often schedule a couple of treatments post-AUS implant to aid healing. How about intraoperatively to reduce the risk of erosion? I will recommend the avoidance of the 3.5 centimeter cuff. In the initial 100 case series of a single surgeon, 52% of the cohort had a history of radiation. They had a much higher risk of erosion, 21% versus 4% in the non-irradiated men. Another paper also reported increased risk of failure with a 3.5 centimeter cuff in the compromised urethra. You may wish to consider transcorporal cuff placement, which has been shown to be effective and safe, either as a primary implant in those with a previous history of radiation or as a salvage procedure. McGeady et al. Showed better outcome with a transcorporal cuff placement compared to insertion of a 3.5 centimeter cuff. However, we know that transcorporal cuff placement is not the miracle cure that we have wished for. In a paper looking at 34 urethral erosions, and most had a transcorporal cuff placement as a salvage, the subsequent erosion rate was 26.4%. Mock et al. Looked at urethral risk factors for subsequent erosion, and the risk factors were prior radiation, urethroplasty, or previous AUS implant. In patients with 2 or more risk factors, the risk of erosion was 52% with those with a transcorporal cuff. Therefore, appropriate patient counseling pre-op is needed. This led to the investigation of the use of urethral wrap techniques. My colleagues in Australia looked at the use of autologous fascial wrap. In 23 patients, they harvested a 6 centimeter piece of rectus fascia wrapped around the proximal bulbar urethra and implanted the cuff outside the fascia. They reported very good short to medium term outcome with a follow-up of 32 months. In their series, one patient had erosion, which is equivalent to 4.3%. Similarly, the use of xenografts may also be employed in the same fashion. In the PPI workshop, during this conference, we heard about the work of Dr. Shenfield with dissecting a local tunica albuginea flap and wrap it circumferentially, which is also promising. Now, I'd like to raise a couple points during implant, and that is, if you have obliteration of the space of retzius, it is not necessary to dissect in that plan to insert a pressure regulating balloon. Ectopic placement, for example, peritoneal, posterior to transversalis or submuscular, has shown to be safe and durable when compared to traditional placement. And as an aside, most of us will use the 61 to 70 centimeter PRB. An interesting paper by Moses et al. Looked at 22 patients who had an AUS, then developed recurrent SUI, and simply managed them by exchanging the lower pressure PRB to the 71 to 80 centimeter. 3 patients of that cohort developed erosion and all had previous radiation. The overall explantation revision rate was quite high in that series. How about post-operatively? Nocturnal deactivation was looked at by Elliott et al. They compared 61 patients who performed nocturnal deactivation of their device versus 49 patients who did not. They reported a lower operation rate and a lower risk of atrophy-related incontinence. However, this was not statistically significant. We currently do not have enough evidence to recommend this management post-op. However, it may be worthwhile to consider in someone with multiple urethral risk factors in whom you have already performed a salvage procedure with transcorporal cuff placement. To summarize, pre-op patient's assessment to exclude stricture and bladder dysfunction is of vital importance. To decrease the risk of cuff erosion, it is best to avoid the use of a 3.5 centimeter cuff and consider transcorporal cuff placement. More research is needed for various urethral wrap techniques and nocturnal deactivation. Thank you.
Thank you very much, Dr. Wang, for that very good summary, given the time that only 10 minutes you have. Any questions from the audience there? I don't think we couldn't see any questions there. So may I ask you a question? May I be a devil's advocate? Because I know a lot of papers have described radiotherapy as a contraindication for sling. But there are different degrees of radiation changes. Sometimes when they have had have radiotherapy history, and then you do a cystoscopy, and the whole urethra looks normal, like there's no signs of urethritis, urethra looks healthy and supple, no stricture, urodynamics, very normal storage capacities. Would you, and the patient is very keen for a sling, would you do it?
I think initially when the sling came out on the market, we all did it in irradiated patients. And the more we did, the more we realized that the medium to longer term outcome is not as good as we have hoped for. So I personally wouldn't. But I agree it's a dilemma. If you have a patient that had radiation and only uses 1 to 2 pads a day, putting an AUS in seems to be an overkill. So I think in very selected patients, if the expectation can be well managed, I may consider insertion of a sling if on cystoscopy the mucosa looks healthy.
Yes, I sort of tend to agree a little bit, but we can always chat about this a bit more in the live lounge, perhaps. This is a very interesting point of discussion. So I think for interest of time, we will move to the next paper now.
Okay. Next speaker is Dr. Nuon Saisung from Thailand. And she's talking about anastomotic or urethral stenosis after radical prostatectomy and management POL. And Dr. Nuon Saisung, please start your lecture.
Hi, everybody. Good afternoon from Thailand. Good afternoon, professors and all participants. Today, I have 10 minutes to talk about the anastomotic stenosis after radical prostatectomy. And I don't have anything to disclose. Anastomotic stricture, or we can call the West, is not common today. Even we found quite high, about 8% incident in previous data. but the incident decreased, which is depend on new surgical technique and which is depend on the different in literature, which as today is found less than 1.4% in kind of robotic assist surgery. And since whereas patient may present with storage symptoms, and even we know that maluse after radical prostatectomy is not is kind of OAB-like symptoms. So in case of high risk of West history, we have to concern that storage symptom could be a presentation of VS as well. And the risk factors such as the high burden or high grade cancer, patient who receive SAWAS radiation, patient who has many comorbidities such as coronary disease or diabetic patient, patient who have the operative factor which makes a poor quality of anastomosis, particularly the urine leakage and infection. And other is the surgeon experience and surgical technique are important as well. The diagnosis of West is because the West symptoms generally presents within 6 months and rarely after 2 years. So the diagnosis needs a tool. We have to exclude recurrent cancer and evaluate the bladder function as well. Exactly, cystoscopy is a reasonable initial diagnosis tool because it's allowed to directly visualize the tissue and easily confirm the presentation of stenosis site. For the goal of treatments, the goals are to prevent urine retention from obstruction, to preserve a physiologic void, and other is be maintaining the continence. We should start first with minimal invasive endoscopic procedure, then go to the reconstruction surgery if it failed for the second choice, and then concurrent anti-incontinence procedure may be needed in some cases. Anyway, the poor surgical candidates or those refusing surgery may be offered urethral or suprapelvic catheter, for long term, and some patients we can offer the self dilatation urethra as well. Look to the outcome of endoscopic treatment. The outcome seems to have a good result in all types, but cannot directly compare due to difference in follow-up time and in each research. With success, is most defined at if we could pass the 16 French flexible cystoscope. Many literature show increasing success rate with the repeat endoscopic attempts. So, be different from bulbar stricture guideline from the AUA, several endoscopic attempts should be undertaken prior consider to go for reconstruction. And if we're looking in detail of endoscopic treatment, no standing out technique of incision is the best, but most of literature makes of a deep lateral incision. We might use a cool or hot knife at 3 and 9 so-called position. And sometimes we can afford the improvement outcome by medical injection at the fibrotic size, such as metomycin C, which maybe end up with osteitis pubis or fistula complications. Other is triamcinolone injection, which show more safe and give a bit high success rate, but need multiple redo procedure. And other is like the AUA recommendation, the transurethral resection by holmium laser to remove the private fibrotic tissue show pretty good result in many literature. Look at the reconstruction outcome surgery. Reconstruction surgery outcome. The most popular technique is progressive version of perineal approach. We're using the technique for pelvic fracture urethral injury. Even some studies show really good result from assist laparoscopic reconstruction, like a minimal invasive surgery. Let me a bit review a goal steps of transperineal reconstruction. First, we have to complete urethral mobilization. You have to mobilize freely as much. And second, you have to follow by urethral transection, the corpora split, and dorsal venous complex ligation may be needed in this point. And now inferior pubis will be exposed, and you might need to pubectomy too. Why excision of the scar is the important point. You have to exist until you see the healthy bladder tissue. Finally, you can complete anastomosis with spongiosum lining in the group of between the corpora. Okay, it's an old fashion of the most of literature suggests the old fashion of pelvic fracture urethral injury. Okay, so this is my conclusion. I would like to deliver to your home. In conclusion, was after radical prostatectomy is rare, but in the modern race, it's ranged from only 1 to 3%, but it's kind of progressive in nature, so we have to concern. The storage symptom may be the presentation of bladder outlet obstruction, so you have to concern. If patients say they have a storage symptom, even they don't have any, they don't mention that they have the poor flow. So patients with high risk factors should be considered to work up for. And of course, the cystoscopy is the gold diagnosis tool. Treatment should be start with multiple endoscopic procedure, followed by reconstruction. It should be open or it should be in minimal invasive, depends on the experience of the surgeon. Adjuvant radiation after radical prostatectomy associated with the risk of failure treatment and complications. Patient with high risk incontinence may be treated, maybe need to have to conceal and need a simultaneous anti-incontinent procedure in some cases, or maybe waiting for 6 months to ensure the mature of anastomosis site. And of course, because the reconstruction is kind of the state of art of urological procedures, so in newbie hands, I suggest you need to call for help. Thank you. Any point or any question to discuss?
Thank you, Dr. Nguyen Saitheng, for nice presentation. And well, as you said at the initial part of your talk, the instance of anastomotic stenosis after radical prostatectomy is decreasing.
Right.
That's because widespread use of robot-assisted laparoscopic prostatectomy, we can anastomose urethra and bladder with a very magnified and beautiful view. So I think that the incidence is decreasing right now. But if this problem occurs, it's very troublesome for the patient. So your talk is very good for many urologists. And
there is a question. There's a question from the audience from Dr. Letitia Decourt. Do you have any personal experience with mitomycin C injection for anastomotic stenosis? Does anyone in the audience have experience?
I don't have any experience to inject any medication in the incision site, but because the many research says it's not different, it's a bit improvement in some research. So in my opinion, I don't have any idea. And particularly mitomycin show very serious complication, right? Fistula and ulceritis pubis. So in my opinion, I don't recommend to do that. You can try steroid injection. It is better because it's safe.
Anyone else in the audience? Anyone else in the panel have mitomycin C experience? No, I do agree with Dr. Nguyen Thai Song there. I personally haven't had experience with mitomycin because it's a alkylating agent and it can cause palmar desquamation and a few other dermatological and other side effects. So I have had some success with Canacort with corticosteroid injection, but no MMC. There's another question from Professor Carlos de Ancona from Brazil. Hi, Carlos. So how many endoscopic urethrotomy would you consider as a failure? How many would you do before you say, look,
okay, in my opinion, we will look, it's just not only the number of the procedure to repeat it, but we also, we have to look at the structure size. If it's really long structure size or if it's really, really bad tissue, maybe we consider to do only a couple times and then have to go to reconstruction surgery. Okay, so for me, it's not no exactly number, but many researchers said that you have to try many, just not only one attempt like bulbar urethral stricture, because we found that multiple attempts help in this ways. That's it.
Okay, so I don't think there's any other questions. So thank you very much, Dr. Uma Phon, for your presentation. So we'll come to the last presentation, which is given by Professor Kexin Su from Peking University People's Hospital, China. And his talk is on the management of post-prostatectomy incontinence in men over the age of 80, management perspective from the country with the most octogenarian. Thank you, Professor Su.
Thank you, Professor Tay, for your introduction. It's my honor to join this session. Oh, yes. I'll talk about post-prostatectomy incontinence in men over age 80. I have no disclosure. And about 70% of AOS operations are performed in men aged over 70 and with increased life expectancy, more octogenarians undergoing radical prostatectomy, as well as male stress urinary incontinence. And the major concern of AOS surgery are the significant comorbidities or frailty of the male stress urinary incontinence octogenarians. So based on this, the negative point for AOS implantation for octogenarians is that many octogenarians suffer from bladder dysfunction. As shown in this paper, with increasing age, their bladder capacity and void volume decreased, and more aging population suffered from more aging population of urinary incontinence suffered from this bladder dysfunction. Another factor is so stress urinary incontinence is the main cause of post-prostatectomy incontinence following surgery for prostatectomy for breast cancer. However, bladder dysfunction may be the isolated cause of urinary incontinence in approximately 25% of patients and coexist with stress urinary incontinence in 30% of cases. Older patients have greater risk of bladder dysfunction, and patients older than 80 years of age may be considered a high-risk group. So urodynamic study is essential to identify the etiology of post-protective incontinence and to optimize the outcome of treatment. So next factor we should consider about cognitive disorders in octogenarians. So important concern required to qualify patients to the LS was obtained during their assessment of the patient's mental and intellectual state. These all patients are often burdened with a number of chronic diseases whose symptoms intensify a poor state of mind. Impaired psychomotor functions may also disqualify them from ALS. Another important element of qualifying to ALS implantation is adequate patient motivation for the surgery. The patient should also understand the essence of the treatment method because together with manual dexterity, it will allow for independent control of the sphincter pump. Therefore, cognitive and other memory disorders are contraindications to this method. And the qualification to implantation and ALS should include a psychological assessment, especially in older patients with suspicion of mental disorders. The positive point of view for the ALS implantation in octogenarians is that the outcome of ALS in octogenarians is comparable with young patients. Based on this study, it involved 29 men for analysis with a mean age of 77 years and average follow-up of 5 years. Overall, about 55% of 29 men reported no complications and needed no additional intervention. Of the 13 men with complications, 4 required revision, 4 required removal, and 6 required deactivation. Another new study showed that no significant difference in overall device survival between age stratified groups and 5-year device survival in those aged over 80 was 63%. So how about the decision making? So the treatment of choice of older men with stress urinary incontinence, based on this paper, when evaluating whether geriatric conditions were correlated with treatment type, neither age nor any of the health characteristics assessed were found to be significantly associated with choice of surgical or conservative management. Incontinence characteristics were significantly associated with surgical or conservative management, with those electing to undergo surgery having greater amounts and the frequency of leakage, higher overall incontinence scores, and greater leakage interference. So identifying and optimizing health characteristics that could affect treatment outcomes might improve individualized assessment, counseling, decision-making, and perioperative outcomes. However, given that male stress urinary incontinence surgery has the potential to offer near-term quality of life improvements to this patient population, male stress urinary incontinence surgery should be considered among men across the spectrum of health and life expectancy. Incontinence characteristics were significantly associated with treatment choice. Those electing to undergo surgery had worse leakage scores and greater leakage interference. Okay. So in summary, health characteristics such as age and frailty are not driving treatment choices or satisfaction. Age and frailty likely associated with somewhat worse outcomes, such as bladder dysfunction and cognitive disorders. Therefore, it is important to identify and optimize health characteristics that could affect treatment outcomes. Treatment of male stress urinary incontinence improves quality of life and should be considered among men with a broad spectrum of health and life expectancy, including octogenarians. Thank you. Thank you for your attention.
Thank you very much, Professor Su. That was a very insightful and detailed analysis of a very special group of patients, which we now begin to see more and more in our practices. We certainly, I'm sure all of you in the audience and also on the screen would have seen patients who have had radical prostatectomy or radiotherapy many years ago when they were in their 50s and 60s, and now they are surviving into their 70s and even 80s. Have you seen in this group of patients, if they've had AUS implanted many years ago, like more than 10 or 15 years ago, have you seen them starting to have erosion issues? Because I have seen in clinical practice when they are over the age of 80, for whatever reason, the tubing, they may erode through the skin, the scrotal pump may erode through the scrotum, and sometimes even the cuff erodes through the urethra. I don't know what is your experience. I know in your literature review, you have described no major detrimental effects when they get to octogenarian age, but in clinical practice, we do see them from time to time. Do you have any comments about maybe these scenarios? Have you seen these complications surfacing in your clinic when they get to their 80s?
Yes, thank you for your question. Yes, based on this paper, yes, more patients older than 80 suffer from erosion or infection compared to young patients. So for my experience about, there are several cases of erosion and atrophy. So most of the patients are older than 80. So I think age do have impact on outcome of AOS, but still many patients satisfied with AOS outcome for the octogenarians. So we can select suitable cases to perform AOS for men older than 80.
If these patients are, say, on aspirin, for their cardiologist put them on aspirin, and you want to do an AUS or a sling on these patients, how would you deal with the anticoagulation? Do you stop their aspirin, or would you let it continue because of a slight risk of
yes, for me,
cardiovascular?
we'll stop aspirin, but for some special cases, I will use injection dosage and stop 24 hours before the surgery.
Sorry, what type of injection?
The short-term anticoagulation.
Oh, I see. Subcutaneous or intramuscular. Yeah. Anyone in the panel have any questions for Professor Su? I'm just scrolling through here. There aren't any questions here. We still have about 2 or 3 minutes. So perhaps if there are no questions for Professor Su, thank you for Professor Su for your very nice summary of this situation. I may go back further up on the list. There is a question from Helen O'Connell to Audrey Wang. Do you have any experience on AMS 800 sphincters? Do you have any experience?
I don't, but I've been looking at the Victor sphincter. I've never implanted one myself, but I like the circular cuff. But I'm a bit wary about adjusting it post-op.
Okay. Okay, so I think we are getting close to the finishing time. So may I let Professor Kakizaki with some closing words, and then we can perhaps all meet in a live lounge after this.
Okay, thank you, Vincent. Today, I enjoyed each speaker's talk very much, and thank you very much for a very wonderful presentation. And as Vincent said, this is the first opportunity for PPCS to have a joint session during ICS. So Vincent did a very good job for this PPCS session, and without his dedication, this PPCS session would not have been materialized. And Vincent, thank you very much for a good job. And lastly, I hope the PPCS will expand and include more Asian countries. And this PPCS is very working as a platform for scientific exchange. And I hope this PPCS will be more successful in the future. And lastly, I'd like to mention about the Journal of Lower Urinary Tract Symptom, the Journal of LUTS. The Journal of LUTS is the official journal of PPCS, and I'm now working as the editor-in-chief of this Journal of LUTS. So please submit your very good paper to the LUTS journal. And this is my last hope. And thank you very much for the speakers and participants. And I'd like to close this PPCS session. And thank you very much.
Thank you very much, everyone. Have fun and enjoy the rest of the meeting. Bye-bye.
Thank you.
Thank you.
Bye-bye.
Bye-bye.
Bye.
Thank you.
Thank you. Bye.
Thank you.